We will quickly go into our last presentation before we go into the panel discussion or question and answer session. So we have Dr. Raymond from South Africa, who will be presenting on HIFU application and its economics in South Africa. You may wish to know that Dr. Raymond has been a consultant gynecologist for over 24 years, since 1986. He is the Vice President of the International Society of Minimally Invasive and Virtual Surgery. It's a shame I didn't know Dr. Raymond earlier, and especially that he's at Baragwana. You know, we know Baragwana as a place where if you are learning emergency surgery, you will see all the different types of trauma at that hospital in one night. In your first call, you will see everything. He trained at VIDS, and he is a trainer of doctors, but more important, he's actually head of the gynecological unit, and he is head of the HIFU unit since January 2016. And being closer to home, I think he will share insights that as Zambians, we can also look forward to. Dr. Raymond, the floor is yours.
Thank you very much. Good morning, everybody. Ni hao to those in China. I'd just like to thank the organizing committee for inviting me to speak at this webinar. I'm Dr. Raymond Setson from Chris Hani Baragwanath Academic Hospital in Soweto, and I'm going to be talking about HIFU application and its health economics in South Africa. Why is it not? No.
Go bottom left, Raymond, on the arrow.
Bottom left on the arrow.
Yeah, that goes backwards. Other one goes forwards. Yeah.
I don't know why it's not. Let me just quickly. Sorry, let me just quickly get my daughter to come here.
That's how I was having to do it.
Yeah, earlier on it was working fine. I don't know what. So if I click on there.
If you click on the right arrow, it will go.
There you
down
go.
at the bottom.
Let me just check and see if it's. So why is it not? It's not letting me. Not letting me change the slides.
Stop the sharing. Probably
Well, I was having to do it on the little arrows down at the bottom left-hand corner.
Where's that?
Okay.
On the
Move your thing to the left. Other way. Yeah, down there. Okay, that goes backwards. That one goes backwards. And the one to the right of that will go forwards.
Okay, there we go. All right, sorry about that. Okay, so I'm going to start my talk now. So we're talking about HIFU application and its health economics in South Africa. Now it's not doing it again.
Wrong arrow. It's the other arrow.
Now I got it. Okay, so just to give you a little bit of background about Chris Hani Baragwanath Academic Hospital. It's the largest hospital in Africa and in the Southern Hemisphere, and it's quoted as being the third largest hospital in the world based on beds. We have approximately 4,000 beds in our hospital. And we service the needs of Soweto, which is a black urban settlement bordering on Johannesburg. And there's a population of about 5 million people in Soweto. So the one hospital supplying the 5 million people. In Soweto, there's a lot of informal settlements, and you can see with outside toilets, but there's also formal proper houses as well. It's a government hospital, and we're affiliated to the University of the Witwatersrand, which is one of our biggest and our best universities. We are the largest training hospital in South Africa. The vast majority of the patients that we treated at our hospital are Black patients. We're the first HIFU center in Africa. We got our machine in 2015, and the vast majority of patients that are treated at our hospital receive free treatment. This is just the entrance to our hospital. It's a very busy hospital, as I'm sure most of the hospitals in Africa are. If you go to any of the casualty areas or any of the special clinics, you'll find lots and lots of patients waiting to be treated. Here are just different clinics that you can see, and one of them is our gynae outpatient department. If you look at the health system in South Africa, it's divided between private and the public sectors. The private sector accounts for only about 15% of the population, and this is funded by medical aids, and this applies to mainly the middle and higher income groups. The public sector is the vast majority of our population, more than 85% of the population. These patients are treated in government hospitals. These are patients of the lower income groups or no income. And as I mentioned before, the treatment is free. And most of these hospitals are chronically underfunded, understaffed, and overloaded with patients. The population of South Africa, we have a population of about 58 million people. And what's interesting is that half of the population are Black females. So you'll see later on in the talk why this is so important. Looking at the profile of fibroids, particularly at our hospital, the majority of patients that we see in our gynae outpatient departments are patients with fibroids and the related complications, mainly abnormal bleeding, anemias, dysmenorrhea, and infertility. And the prevalence of uterine fibroids is 3 to 5 times more common in Black women than in Asian or Caucasian women. So with fibroids being so prevalent and with having such a large female population, you can see that our hospital is inundated with fibroid patients. If you look at the profile of our patients, as I mentioned before, they're mostly Black females. The vast majority are on the obese side. We have a very high incidence of HIV. Our patients are late presenters, so most of them will present with a large uterus with multiple fibroids. Another interesting factor, usually fibroids present 30, 35 years of age. We see patients as young as 18-year-olds presenting with large 12-centimeter fibroids, and also their symptoms are very severe. We also have a large proportion of our patients are infertile. But again, this is not only due to fibroids. We have a lot of pelvic inflammatory disease and male factors as well. So just in terms of the obesity, and this is important when it comes to surgery, by the age of 20, probably half of the females in South Africa are overweight. And by the age of 45, this is increased to about 82%. So you have all the complications with traditional treatments, such as surgery, laparotomy, wound infection, wound breakdown, and the surgery itself is very difficult. Also, as I mentioned before, our high rate of HIV infection, probably about 25% of women in the reproductive age at our hospital are HIV positive. And when you're operating on big multifibroid uteruses, there's always a danger that somebody, one of the medical staff, whether they're trying to give you better exposure or they're swabbing or something, bladder wave where you're operating, there's a very good chance that someone's going to get pricked or cut. So we're very careful when operating on these HIV patients. As I mentioned, they present late. This is for a number of reasons. They first go to traditional healers and herbalists. And when all of these fail, only then do they come to us for treatment. A lot of them, especially the infertile patients, see a mass growing in the abdomen, think they might be pregnant, and therefore don't do anything about it. As I said, they don't come for routine checks. Usually, there is a marked fear of hospitals and a fear of surgery. So these are reasons why our patients present late. And as a result, this is the kind of uteruses that we see. Big, massive multifibroid uteruses. This is what the MRIs look like. In terms of infertility, this is very important because there's a lot of, we know we've got 9 different tribal groups and they have all their different traditions and cultural beliefs. And one of these is that in order to get married, you have to be fertile. So a woman who can't produce a child won't be able to get married. And also the greater the number of children that you have, the higher your social status. So therefore, there's an intense desire to preserve the uterus. So again, when we have a patient with a large multifibroid uterus and we mention myomectomy and make them sign for hysterectomy in case we can't stop the bleeding or something, then they refuse surgery. So infertility is a big issue and these patients are very worried about losing their uterus. Socioeconomic issues. At the moment, there's the unemployment in South Africa is very high. And patients who are coming in for traditional treatment, like a myomectomy or hysterectomy, they're going to be off work for a minimum of about 6 weeks. So it's very difficult for them to get leave, and they're worried that when they get back from leave, they might have lost their jobs. So again, a lot of the time they will delay having surgery. So what is the burden of traditional treatment of fibroids on the healthcare system? So for us, admissions, as I said, our wards are very full. A patient who's coming in for a myomectomy or a hysterectomy will be in hospital for a minimum of 6 days if everything goes well. If there's any complications, obviously that will be longer. So there's a massive cost burden on the state for all of these patients. Even though it's a government hospital, it's worked out that it's around about 3,000 Rand in our South African money per day to have a patient in hospital. And also this leads to overcrowding of the wards. Again, when you're operating on these big fibroid uteruses, you usually lose quite a lot of blood and you probably will need to transfuse patients 1 or 2 units of blood. Blood is expensive, it's a scarce commodity in South Africa. So this is another problem for us using traditional treatment for fibroids. And as well, on our surgical lists, we've got a backlog of over 450 patients waiting for myomectomy and hysterectomy. And this means that patients are going to wait at least another 8 months to a year, in which case the fibroids are going to get bigger and their symptoms are going to deteriorate. So just looking at the development of fibroid treatment over the years, you can see how we've gone from very invasive procedures like a laparotomy for a myomectomy or hysterectomy, going on to less invasive but still invasive vaginal hysterectomies. And then you move on to your minimally invasive procedures where you're now using endoscopy, so laparoscopy, hysteroscopy, and also uterine artery embolization. And now with HIFU, we've got a totally non-invasive procedure, which is based on ultrasound imaging. This is a machine that we have at Baragwanath. It's the model JC200. Looking at the healthcare benefits of HIFU for the hospital. So as we've mentioned before, the patients who are coming in for a laparotomy will be there for 6 days. We are now doing our patients as a day case. So they will come in the morning, they'll have their procedure. We wait until they fully awake from their conscious sedation, and 2 or 3 hours later, they go home. So we don't have any more hospital admissions. So there's a decreased cost on the state. The wards are more manageable. No general anesthetic is given. It's done under conscious sedation. So we've freed up our theaters for more urgent cases, ectopic pregnancies, malignancies, all those kind of cases, which also have a long waiting list. As Professor Cranston mentioned earlier, sorry, I'm confused over here. It's totally non-invasive, so there's no blood loss. And as I said before, blood is expensive and it's a scarce commodity. There's no blood loss with this patient, so we don't have to worry about blood transfusions. And there's no risk of HIV transmission. No, we don't have to worry about needle stick injuries. There's no involvement with the patient. The patient lies on the table and we're working from off a computer. So it's a very safe procedure with very low risk of complications. When you're operating on these big fibroids, the chance of damaging bowel, bladder, the ureters is very high. With us, because it's such targeted, precise management, we don't have these injuries. What are the benefits to the patient? Well, as we said before, being a day case, then don't have to be admitted. No, with our patients, they have to organize people to come and look after their houses, to come and look after their families. So they don't have to worry about that. They're in and out on the same day. Because they're only given conscious sedation, the recovery is very quick. Within a couple of hours, they're fine. They return to work within days. I'll show later on how much time they usually get off with the different kind of procedures, but they normally return back to work within days. So job security is very important here. Because it's non-invasive, you've got uterine sparing. If you're doing a myomectomy on a patient with multiple fibroids, sometimes they bleed, you can't stop the bleeding, or you've removed so many fibroids that there's very little uterus to reconstruct, and you need to continue with the emergency hysterectomy. With our procedure, that doesn't happen. The uterus is spared, so they retain their fertility. The myometrium is not even damaged. We spare the myometrium, so if the patients fall pregnant, they can have a normal vaginal delivery, whereas if they had a myomectomy, they would have to have a cesarean section. As we mentioned before, they can return to their normal activities, exercise, etc., quickly within days. And the other beauty is there's no adhesions. After a myomectomy, we usually find marked adhesions in the abdomen, bowels stuck all over the uterus, mentum. With this procedure, there's no adhesions at all. And this is a point where Prof. Cranston mentioned earlier on, there's no ionizing radiation. So the treatment can be repeated as often as you like. So sometimes when we've got a patient with multiple fibroids, we can't treat them all at one session. So we'll treat, say, 4 or 5 fibroids, and then bring them back in a couple of months and treat the others. And if we have treated a fibroid and we haven't got 100% ablation, we can always go back and treat more on that fibroid. Again, there's no damage to ovaries. So with like uterine artery embolization, there is a chance that you can cause damage to the ovaries by blocking off the blood supply there and getting premature ovarian failure. With us, we're far away from the ovaries. There's no damage to ovaries. And also it's important in our young ladies, they don't want to have scars on the abdomen. So cosmetic reasons are also important here. This is what the skin looks like after treatment with your different kinds of treatment. There you've got, first of all, you've got your laparotomy with a nice scar there. Laparoscopy, even though there's less scarring, you've still got multiple little scars. And with the HIFU, the abdomen is completely normal. Just to show you the comparison of recovery time for the different procedures, with the ultrasound guided HIFU, which is what we do ultrasound as opposed to MRI, 1 to 2 days. The pain they have is very short-lived after the procedure. Within 1 to 2 days, they can go back to normal activities. If they were having a laparotomy and a hysterectomy or a myomectomy, they normally get booked off about 6 weeks. For laparoscopic procedures, it's 2 to 3 weeks, and for uterine artery embolization, it's usually 2 weeks. Just to show you quickly some of the South African results. To date, we've treated 525 patients. Mean age of 31.5 years, ranging from 18 up to 45. Our cutoff was initially 45 because we were sort of more concerned with fertility, but we've now gone up to the age of 50. We don't go beyond 50 because we're just worried about Lyme sarcomas. As you can see, the weight of our patients on average is about 79 kilograms. The biggest patient we had was 115 kilograms. And abdominal wall thickness, one of the issues with the abdominal wall thickness is you shouldn't go beyond 6 centimeters because then there's an increased chance of burning the skin. So on average, ours was around about 5 centimeters. So our patients are on the big side. Just to show you here, most of the fibroids that we treated were on the anterior surface of the uterus. Most of them were intramural. The other thing that we look at that's important when treating the fibroids is to, on your MRI, you look at the T2 signal intensity and you work out whether they are hypointense, which means they are darker compared to the surrounding myometrium. This means they're less vascular and they're easier to treat, whereas the hyper means that they're brighter than the surrounding myometrium, usually more vascular, and they're going to be very difficult to treat. So luckily ours were mostly easier to treat. If you look at the symptoms that all our patients complained of before treatment, the vast majority complained of dysmenorrhea, menorrhagia. A lot of our patients, because they're late presenters, had anemia, HBs below 12. Infertility is, as we mentioned, a big issue, and then also constipation and urinary symptoms. Adverse events during the HIFU treatment. This is done under conscious sedation, so the patients will complain of some pain. Low abdominal pain is normal because we are creating ischemia in the fibroid, and about 78% of the patients complained of that. It's usually of short duration, and it's usually managed by the anesthetist. Some of them, especially if you've got posterior fibroids, complain of sciatic or buttock pain. Burning sensation on the skin, you've got to be careful of because we can get skin burns. 31% had that, and 14% had transient leg pain, which is also you need to be very careful of. In terms of major adverse events that we've had so far with our over 500 patients, we've only had 2 cases of first-degree skin burns, which were managed conservatively and healed spontaneously within 2 weeks. And none of them required grafting or anything. We haven't had a single bowel injury, bladder injury, or ureteric injury. We've had 2 cases of nerve injury where the patient had some pain down the leg, and that also resolved spontaneously within about 6 weeks. All the patients get quality of life scores before and after treatment. And if you look at the before, the quality of life, the score was low, around about 35. And you can see how after 1 month, 3 months, 6, 12, 24 months, the quality of life improved. And after 2 years, we monitored them up to 2 years, the score had gone up to about 75. So there was a marked improvement in the quality of life. We also do symptom severity scores on all the patients, pre and post. And you can see that before the treatment, the severity of their symptoms was high, just below 60, and how with time it dropped, and down at 2 years it had dropped down to below 20. So there was a marked improvement in their symptoms as well. Shrinkage rate, we found on the first 100 patients, this was done at 1 month, it was about 31%, up to 52% at 3 months, 61% at 6 months, and around about 73% at 1 year. In terms of fertility successes, we've had 22 cases of pregnancy. 8 patients are currently pregnant at the moment. We had 1 4-kilogram vaginal delivery. We've had 13 term cesarean deliveries, of which 1 was twins. And these figures, we might even have a higher number of pregnancies. The problem is we have very poor follow-up with our patients, especially patients who are coming from, we have a lot of patients coming from out of our borders and from other provinces. And often what happens is they'll fall pregnant and they just don't communicate with us and just continue seeing their doctors wherever they are. So our numbers could be even higher, we're not sure. This is just a baby gallery to show you some of the pregnancies that we've had. These are just some of the cases that we've done. A 40-year-old patient, you can see pre-HIFU, fibroid there, and then you can see 1.5 months later, it's now ablated. Most of the fibroid is ablated, and it's already shrunk by about 27%. In this case here, in this 32-year-old, you can see the fibroid there, 4 months post HIFU. Also about 98% ablation, shrinkage was already about 63%. There's a 27-year-old patient, this is at 23 days, ablation rate about 71%, and it's already shrunk just about 10% after 1 month. There's a 42-year-old with multiple fibroids. 2 days post-treatment, you can already see quite marked ablation of the fibroids. So in conclusion, for us, HIFU has assisted in transforming women's healthcare in South Africa. It's made a huge difference to them in terms of their symptoms, their quality of life. It's a safe and effective alternative treatment for uterine fibroids in Black women. From the patient's perspective, the uterus, the most important thing, the uterus is retained, and therefore their fertility is retained. They have a quick recovery, they're back to work, they're back to normal activity, exercise within a couple of days. They can have a normal vaginal delivery post treatment, which is important for us because in our hospital, we have a waiting list of emergency Caesars. At any one time, we could have 20, 25 emergency Caesars on the board. So if we can get away with doing normal vaginal deliveries, it will make a big difference to us. And from the health system perspective, being a day case, the hospital admissions are reduced, therefore the costs are reduced, the wards are more manageable, there's a marked decrease in the blood requirements, and patients are getting quicker access to treatment instead of waiting up to a year for surgery. So in Africa at the moment, we've got one machine right up at the north of Africa in Egypt. We've recently got a machine in Nigeria, and right at the bottom in the south, in South Africa, we've got a machine. So we've got 3 machines in Africa at the moment. Thank you. Thank you for listening.